Dario Francescatti. I'm a surgeon. I work at Rush, and I'm also the part-time medical director at Zoft. This evening, we're going to talk about a subject that is really very, very exciting to the surgical clinical world, and I think also to radiation oncologists as well. We're going to talk about single fraction intraoperative radiotherapy. And with that said, I'm going to give you a very brief introduction on the technology and perhaps some of the clinical reasons why we think that this is going to be a great quantum jump in the treatment of breast cancer for women. Dr. Randy Holt is a physicist. He's going to explain a little bit of the intricacies of things that we surgeons don't ordinarily think about, but I'm sure the radiation oncologist in the audience will appreciate his talk as well. Then we're very lucky to have Dr. Silverstein from California. I'm sure most of us in the room realize that he is been an icon in breast surgery for many, many years, and we're fortunate enough to have him here tonight so we can listen to his presentation. That's going to be followed by Dr. Schwartzberg, who is at Rose Hospital in Denver, and she is a breast surgeon who is actively treating patients with the Zoft system for IORT, and actually has a poster upstairs, and perhaps over the next day or so you can see her poster. And then finally, we're going to have Kathy Francisco from the Pinnacle Health Group talking about some reimbursement issues. Intraoperative radiation therapy. This is a standard operating room, little company of Mary Hospital. No modifications required. The only thing we needed was a long extension cord and also a screen, a leaded screen that we would stand behind. The anesthesiologist can stay with the patient. The idea being that we can deliver therapy rapidly in a safe environment in a standard operating room. If we look at the evolution of radiotherapy, we can go from full breast radiation of 6 to 7 weeks, which has now been actually reduced in many institutions to 3 weeks. We took a big jump in the about 1992, where we started to do 5-day treatment. And I might add that one of the pluses of the Zoft system is that you can perform 5-day APBI with the system as well as IORT. If you look up here at the last picture, indeed, beam time on in the operating room can be as little as 8 minutes. What's the incidence of breast cancer? If we look at the United States, we're talking about roughly 250,000 cases a year. If you break that down and you take the, I'm at a loss to really put a color name on the blue up there. If you take that and break it up, you're going to find that in lumpectomy, we can do roughly 43% with RT. There's 37% of patients who will have a mastectomy with their diagnosis. And if you look at that 20% who receive a lumpectomy and then do not receive radiation therapy, that segment of the pie is essentially undergoing substandard therapy. If we had a means to deliver therapy during surgery where many of the socioeconomic factors that affect us all come into play about how do we get to the hospital for therapy, is there a hospital near us that can provide that therapy, we can start to realize the impact that this system will have on radiotherapy as far as patient convenience and, I might add, patient choice. Many times, a patient will choose a mastectomy because there is no other alternative. I think that's something that, as a group, as surgeons, as radiation oncologists, we should consider trying to improve upon. We also find that the distance from a radiation facility is also a very, very critical factor as far as a patient having their therapy, deciding, gee whiz, you know, I don't have a ride, I have to go to work, my son can't pick me up. Why don't you do a mastectomy? Or I'm just not going to have all of the therapy. So you can see that life gets in the way of lots of patients in picking a therapy. As I mentioned before, standard operating room. This is the system, which is the most mobile system that is in existence today, if you can believe it. This is the, I call it a gizmo. It fits on the end here, but this is the source applicator. And this system is actually cleared for breast as well as the rest of the body. So how many of you here are still doing some general surgery? All right. If you think about that, this source is so small and can be shrunk smaller that eventually, I believe, this is going to go down an endoscopic tube. Right now, it can go through a laparoscopic port or the robot. So we're talking about a platform technology. This is the back end of the machine. This is the one we deal with. Here's an arm that can be placed in many, many positions so that in approaching the patient, we're not frozen to one position as far as the appliance exiting the wound. We can exit vertically, horizontally. We can even go percutaneously. So there's really no position that the patient can be in that this machine cannot basically be placed so that treatment can be initiated. This is the working end for the surgical parts, the balloon applicator. After the lumpectomy is formed, we will place a balloon and we will make sure that there's 100% apposition of the cavity around that balloon. We set things up so that once we're sure via ultrasound, once we're sure that the radiation oncologist has verified that there's 100% apposition via ultrasound, treatment is commenced. We have a number of sizes. We can fill a surgical cavity from 30 cc's to 130 cc's. Now I know most of us here don't make a 130 cc cavity, maybe except for my friend over here on the left, but he does it with the plumb and with a little bit of technique difference from many of us. One thing I want you to note is that there are drainage holes here. These drainage holes are oftentimes used to either evacuate seroma or air, and that was usually very useful for APBI. In the operating room, when we're doing IORT, we can take this port, we can hook it up to suction, and by doing that, we can cause a vacuum in the cavity and pull the breast in even tighter to make sure that we have absolute apposition of the cavity around the balloon. It's more efficient in the operating room because this works at 300 microamps, which means on average for a 4 centimeter balloon, our treatment time is about 11 minutes, whereas other systems up to 27 minutes. So this system delivers treatment 2.5 to 3 times faster than other systems. So finally, the benefits of selecting Xoft. It's economical, both on a socioeconomic level, as far as personally in the operating room, less treatment time or on-beam time. It's extremely mobile. It can be taken from room to room, from department to the operating room. You can throw this on the back end of a pickup truck with a generator and deliver therapy. I oftentimes kid the radiation oncologist and I say, you know what? This is so mobile, you might even have to make house calls. And then once upon a time in an audience, a hand went up and it was a radiation oncologist, and the radiation oncologist said, what's a house call? It's versatile, as I mentioned, it's platform technology. We treat the area of greatest risk, which is essentially the area that we've removed. Less time in the operating room, it's convenient for the patient, and it's green technology. When it's on, it's on. When it's off, it's off. So it is a true breakthrough, I think, in the delivery of radiotherapy to the breast patient.